Okay, hello everyone and welcome to this webinar today. I'm Francis Seeley from GlobalNet 21 and Input Voices, and this is one of the many webinars we do. We try to do them once or twice a week. And today we've got Michaelene Gail Holder-March with us, who runs a project she'll tell you about in a minute, where she works with communities from Black and ethnic minorities. And particularly in the area of health, where there are particularly problems of access and so on. And we're going to try and explore that today. Anyhow, Michaelene, thank you for joining us today. And maybe I could start by asking you to tell us a little bit about yourself and the journey that you made in order to, be where you are today.
Okay. Hi. Thank you, Francis, for having me on, and thank you to all the listeners and participants out there. I just want to say my name is Michaelene Holder-March. I'm Trinidadian born, but I'm British, and I've been a nurse, midwife, trained in law and management. I've worked up in many organizations, both private and public. I have my own company, MHM Health Consultancy Limited, MHM Business, and I also have a necktie for men business. I have worked in strategic positions and operational positions. The reason I'm here today is because I'm the founder and the chair of BAME Health Collaborative, which is known as BHC. And the reason that was formed is because of the disparities in healthcare in regards to BAME communities, and also because many of our healthcare professionals, as you know, have lost their lives. And this has seriously impacted families and also impacted their friends and colleagues. And it's to address how we actually look at the pathways and the journey of healthcare professionals who are working very hard in the NHS.
Okay, well, let's go through some of that step by step. You talk about BAME communities, but I was watching a webinar with Kate Osamar, who's the MP in Edmonton, and she's saying she doesn't like the term BAME communities because it lumps everyone together in one group, and they're different communities and they have different health needs. Is that something that you share as well with her?
Francis, there are so many different terminology out there to reflect different groups, and there are always personal preferences. However, we use the word BAME because that's what is used in government documentation reports, and until there is an agreed change of wording or abbreviated words, unless there's an agreed change in regards to that language that's being used, BAMEs, or some people don't want to be called BAME. As long as it's agreed, I'm happy to go with that. But we have to remember that there are minority ethnic groups who must not be lost in the narrative.
Obviously, those minority groups have grown all over the years, in the last 2 or 3 decades particularly. And have you discovered, as that's happened, that there are barriers to them actually accessing health and particularly mental health services?
What I can say is that one of the most positive things is that in each of these communities, there are champions. There are people who are working to actually bring their issues and concerns to the forefront. The good thing about BHC is that we have people from the Chinese community, the Bangladeshi community, we have people from the African community, Afro-Caribbean community, so we try to engage all communities as much as possible, but we are open to working quite closely with community leaders of all ethnic groups so that we can work on this together. It's a together plan. It's not an isolated plan.
When you say work on this together, what is the this that you're working on?
Work on a strategy for change. Work on a strategy for change. And how do you work on a strategy for change? There is 5 pillars, really. One is listening to the concerns of the community. What are the key concerns? 2, how is that communicated to the people who make the decisions for them? 3, getting people from their community to be part of the healthcare framework, the workforce. That is really key, whether they are there as volunteers, whether they are trained to become healthcare professionals. And, and the fifth one, which is really important, is reviewing how that works and making sure that people have amply enough information so that they can actually empower their communities in the right language and it's culturally sensitive.
So are you working to help get more people from the BAME communities into the health professions, or are you also working to try and empower the communities themselves to find ways of getting better health?
I think we need to start a little bit nearer to the bone, and that is clinical guidelines. So that's what we're working at, the policy, the procedures, and clinical guidance. So all the clinical guidance that we have that has been implemented and rolled out and being followed, and the journey and the pathways that's been decided, we need to be on the table of that discussion. We need to be part of those clinical guidance to actually work on it. For example, one of the things that I keep saying is the men who suffer from breast cancer. I know I keep championing this, but men who suffer from breast cancer are happy to go to breast clinics from the Caucasian background and sit in a breast clinic. But most men from the BME communities are reluctant to be in that environment. And it's how we targeting that, how we dealing with that, ensuring that people have translators who will be able to advocate on their behalf. It's deeper than just the traditional offering of service, making it a little bit more bespoke and understanding that it's an individualized pathway, take it into context the culture and practices of the people that you treat.
So there are two sides to that, aren't there? There's getting the person, you mentioned a person from the BAME community who may have cancer, getting them to understand that they need to use the service and helping them and advocating for them, but also getting the health service as well to understand the different needs of the diverse communities that you work with and to connect with them in a way that's appropriate.
Yes, there was something called the cycle of health disparities. And, it looks at the environmental aspect. And the environmental aspect is that, are they utilizing, are they living in an area where it's really congested? If they have children who are suffering from asthma, how do they deal with that? Are they accessing the right care? You're looking at the health risk factors, as you know. And, you may know that in the Black community, diabetes, and also in the Asian community, diabetes is one of our biggest illness that really affects us. And it's how we actually, it's our food, what we eat, and it's all about that engagement. But within the Black and African community and also the Asian community, it's about getting that language into whether it is Punjabi, whether it's Igbo, getting that language written so that people can actually understand it and not expecting people to fully understand because you converse to them in strictly in English language. It's about using the translation and communication service to actually ensure that people get optimal care.
So when you talk about health disparities, social disparities in health anyhow, is that what you're talking about? That different communities suffer from different things? You mentioned some there, sickle cell anemia, for example, the Black community and the Cypriot community, particularly the Greek Cypriot community. Is it understanding that and getting them to understand that and trying to work with them on the basis of that understanding?
Yeah, if you look at the social and economic aspect of it, we know for a fact that limited education, and we're not talking about going to a university, getting limited education to give people health education. It's one of the factors that actually impacts on long-term positive health outcomes. So you have to give the right education. And how is that education being shared in the communities? So that's one of the things. The other thing is that employment, the type of employment that BAME communities, the men and the women engage in, whether at the lower end, whether it's the cleaners, and at the upper end, the healthcare professionals who are on visas and actually doing long hours and don't want to sort of say, well, actually, I can't work because they're fearful of their employment contracts. It is about income, generated income. We know people from the BAME communities do, on a large proportion, much lower than their counterparts. And it's taken all of that into context and how that actually affects the mental health and well-being of that individual.
So is it a sort of vicious circle that health disparities can cause inequality, and inequality can cause health disparities as well?
Yes, it's a trickle effect. It's a trickle effect, and it's about how do we go about doing that? What are we going to do about that? For example, if you look at pregnancy vulnerability, poor prenatal care. Why it is that for the baby community we talk about poor prenatal care, and there is enough evidence for that. It's the time, the availability of prenatal care, and not wanting, some women, they don't want to be in a room where the other women have their partners with them. It's about looking at it. I'm not saying that we have to spend a lot of money in transforming and making significant changes in the care that we offer in developing services. But what we can do is be a little bit culturally, not a little bit, we have to be culturally sensitive in the services that we offer.
And you say,
we have to engage.
When you say we have to be culturally sensitive, who are you talking about?
All of us. Because, there is something called implicit bias. And it happens, it's a human factor. It's not racially pigeoned or boxed. It's really about that implicit bias that we all have. And it's a human failing, really. So it's about when you see someone, what is the first thing that comes to mind? And I know that Guardian did a big thing about implicit assessment, but it's really about you consciously, cognitively thinking, what care am I going to offer this person? And instead of just doing that blanket approach, what do they need? Look at patient history is very important. A patient history is important. And it's really important to look at a patient's history, the social history, and actually assess there and then, what do they need? No healthcare professional actually leave home and go into the workplace to be discriminatory, but there's something called implicit bias, and we have to be aware of it. And we have to actually self-assess ourselves when we're offering care.
So is that something that you do, try to get people to open up about their biases and their prejudices and to talk about it? Because once they do that, they begin to understand each other in a better way.
Yes, well, we aim to do so. It's a very new, it's a new organization. We are growing, and there are so many challenges with that, but we are growing. It's an uncomfortable conversation, no doubt about it. But once we are able to do that and understand each other, where the person's culture, their background, their concerns, their imperfections, once we're able to do that, we will really have a much more harmonized culture to work and live in.
Yeah, I'm just reading a book now. I don't know if you've heard of it, called White Fragility, and it's about, you have, well, it's about how white people are, especially progressive white people, are fragile about confronting and talking about racism because they think that's racism. But in a way, what that book is saying, we have to open up. We have to understand, what our subconscious prejudices are. And I guess that's important for you in the health environment. People need to open up about their differences and their needs.
Yeah, and it's most of the time, it is about really taking time to sort of understand the person that you're communicating with. So therefore, the first visual that you see, you need to put that aside and really understand and ask the person the relevant questions, so that care that you're going to offer will be the same that you will offer a Caucasian male or a female. So there's no sort of perception of that person. So I'll give you a classic example. I had a fall many years ago, and I had a really terrible fall, and there was a hairline fracture. And I got to the A&E, and when my husband arrived, they were interrogating him because they thought he had abused me. I was a victim of domestic violence, which domestic violence is real and it should be reported. And I am really one of those who stand with women and men who've experienced that. But there was this perception, and she said, the healthcare profession will say, yes, it is common for Black men to do this, which is it's a stigma. It was so far removed. So it's about our language, our perception. It's about removing all the stigmatization, removing all the rhetoric that you hear. And actually, when someone needs your care, because that's what you have actually signed up for, you're going to treat them equally.
But I guess I guess the professional who said that about, well, Black men are like this, he or she didn't think they were racist. They thought they were just dealing with a problem that they see every day, but they just didn't understand the implications of what they were saying.
Yes, yes. They didn't understand at all. And that was sort of like a blank. And I'm sure my husband wasn't the only person they would have said that to, but that blanket approach is not acceptable under any circumstances at all, you know. And if we reverse that and say to a white male or a white female, you domestic, in regards to domestic abuse, it will be an uproar. It will be, there'll be complaint letters, there'll be all of that. It'll be taken in a different vein. So I think we need to sort of, look at scenarios and put yourself in that person's place and sort of sit back and say, what am I doing? Am I doing the right thing?
So
am I jumping to conclusion here?
Yeah, so do you run sort of engagement sessions, workshops around this? Because I remember, the book I mentioned, White Fragility, Robin D'Angelo, I think it was the person who wrote it, and she was saying she runs workshops as well and confronts the sort of issues that you face. And white people particularly, and I'm sure it happens with people of all communities, when they're confronted with these things, they get angry. They say, it's not me. I don't have a racist bone in my body. And so it's hard work. Do you have to deal with that? Do you run workshops which deal with things like the one I've just mentioned?
Okay, so through MHM Health Consultancy, I do run the cultural sensitivity workshop. I must say that it's for boards and senior management. However, I do get people who are reluctant to open up in those sessions, obviously, because they don't want to be called a racist. They don't want to be, seem to be having any sort of racist views. However, most of the time, it's taken on board quite well. But it is a much needed, because people afterwards, their feedback is very interesting. I never thought about that. I never thought my behavior is actually seen as racist. I thought my behavior was employment related rather than racist, that sort of thing. But if you give them the work tool where they sort of do it, approaching the same questions, the same behavior with someone who is Black or non-BME, it's quite different outcome. It's very interesting to see the outcome.
So you said you do that there, but you also have the Health Collaborative, don't you? And
yes.
What's the difference? What does that do? It's different than what you've just said.
Okay, so the BHC is, we just registered to become a charity, yeah? And that is voluntary work. All the ambassadors, the trustees, the community leads are all, volunteering their time. And what we're actually doing is trying to change the platform of health that is offered to BME community right across the board. And we have successfully actually become a stakeholder with NICE, which is the National Institute of Clinical Excellence, so that we can actually contribute to some of these guidelines, including prostate cancer, breast cancer, and we have also signed up with the World Health Federation for Incontinence, which is based in Netherlands, to actually sign up and be a partner in regards to incontinence and how that works. Because for BAME community, especially the Black and Afro-Caribbean women, we have larger hips, and most of the incontinent pads are made for the really slender woman, and it doesn't take into context our posterior and all of that great stuff. So we're partnering with them in regards to the recognition that, that these products are manufactured and they're made every day, and they're sold in all the top shops everywhere, but it is not really ideal for us women.
I didn't think we were going to get into a discussion of incontinence on this, but
but
that's,
so incontinence is a health issue, and it could
yeah,
be due to
yeah,
diabetes, it could be due to just pelvic floor exercises, it could be due to bladder, so many other things, but it's something that most people feel ashamed to talk about. Yeah.
yeah, yeah.
But the worst part is being ashamed to talk about it, but not having the right, you know, incontinent pads to wear. It doesn't help. The skin tone, the color tone of it as well is another issue. So there's so many other factors, and we have actually BHC has really done successfully in regards to meeting some of these milestones very quickly.
So you do that in the collaborative network by creating partnerships, but
Yes.
in your other sort of endeavors, you do the workshops and you do other things. What other things do you do?
So so there are three things that we're also doing. We're also doing some mini series, some education series on different topics, whether hepatitis, breast cancer. So we're doing a lot of webinars on education. We also have, this is the really powerful thing, is that we have a community lead called Tanzila Zaman, she wouldn't mind me saying, who is one of the leads for the Bangladeshi community. And she is doing some great work. She's going to be doing some work with us in actually pushing out the message out there in regards to education, looking at some of the public health education bulletins and actually making sure that that is in language that everyone could understand, especially in the Bangladeshi and different communities. So it's not about just making it simple, but making it very much user friendly that they can actually share with their families and friends.
Do you also do work with older people from the BAME communities? Because I gather they've been particularly neglected. Quite a lot of research has shown that. And I gather young carers are 1.5 times more likely to be from BAME communities. So that's a real challenge, isn't it?
It is a real challenge. We haven't actually, I can't say what we haven't actually designed a strategy for the elderly in the BAME community. However, we are really super excited by one of our ambassadors, whose mom is, I think she's over 80, who is actually a keep fit champion. To see her exercising and all of that, I have said that we really would like to use her as part of our ongoing message about exercising and how that helps. And he's super excited about actually introducing her. So we are doing different aspect to the whole BAME health. So we could only do small areas. We could only address small areas once at a time. So we are doing right now is prostate cancer, hepatitis, breast cancer, and also incontinence. And then we have a calendar of what we'll be doing. We also will be engaging with mental health as well. So we have community leads who are responsible for different areas. And that's what we intend to do. We're looking at acute, we're looking at primary, and we're looking at end of life as well. So it's a huge task and everyone is working. And this is on a volunteer basis, and we're very fortunate for that. But we could only, the iceberg, you could only chip a little bit at a time because it's a huge iceberg for us.
So, I mean, you've got about, I don't know how many it was, 2, 3, 4 companies or organizations, I'm not sure what they are, doing different things, and you've explained some of them. Are they all voluntary, and how do you get the people together to work on it, and how do you yourself manage all of that?
Okay, so I'll start with myself. There are 10 trustees. So this is not about Michaelene at all. This is 10 trustees and ambassadors who are doing a lot of work behind the scenes. We also have volunteers, and we also have community leads who play a very much a significant role in regards to helping with the administrative aspect and also reaching out to community leads out there. We have community leads who are actually reaching out to us now in regards to working quite closely with them so that the message can be shared. We also have one of our community leads is a pastor of a church, which is great because the Christian community is important, and church community, that's a family of its own, so we need that engagement. So It is, and as I said earlier, this is a new organization. We are aiming to work collaboratively with all communities, right across community groups, right across the board, so that we can actually write reports that are significant using qualitative and quantitative data to reflect what is happening in the BAME community. Do you know something, Francis? This might stagger the people who are listening. Do you know we don't have a register of BAMEs who may have died? There's no register. If you go to a hospital and you say, can you tell me how many people from Nigeria died within the last year? They couldn't tell you. There's no register. There's no ethnicity register for deaths, which is alarming. So we can't even look at statistical evidence to actually date it. We can't even do anything with that. So it's about, there's lots of areas that has to be addressed. And as we on that as well, even in regards to employment issues and bullying and harassment in the workplace, because we know BAME communities face a lot of that in different sectors. There is no database for the bullies to be put on or anything at all, so that they just move from organization to organization. And the bullying effect has significant impact on staff in regards to the mental health and well-being. So to get that information from their GPs and those who prescribe medicine for them is another tool.
And of course, at the moment, we've got the COVID-19 crisis. Has that given more urgency to what you do? And has it created for you any more problems?
The COVID-19 is a great eye opener, because you look at it on a comparative aspect of, how many have died. When you have a pregnant nurse died, she should not even be there. And the COVID-19 is one of the reasons, for the first time, you have a BAME clinical assessment, which really should have been done earlier in the day, but we have one. It may not be perfect, but we have one. And the COVID-19 certainly opened the corridors for us to actually address some of the key issues that has been affecting the BAME community for a long time. It has opportunities, and it also have dilemmas attached to it as well.
I mean, that's interesting. Obviously, COVID-19 is a tragedy for many, many families. Mm-hmm. But you're saying that, whenever there's a tragedy, you can create a sort of silver lining in it. And for you, it's increased the need for the sort of data you want. And it's made people see they need to get that data. And you're really sort of going in on that and taking advantage of that and saying, right, we've got to take this further. Have you? Is that something that you're putting pressure on?
Yeah, because data is king. Data is king, and having evidence to support any action that you want to take is the only way forward.
Okay.
It's the only way forward, because you need the statistical evidence to show that this is why this is happening. And so therefore, if we at this point now where you cannot tell me on an ethnicity basis how many have passed, how many of this group or that group, it tells me that we have a lot of work to do at the moment.
And in that work, what is the biggest thing you would like to achieve? What's the one thing that for you is most important of all?
The most important thing is the mental health and well-being of healthcare professionals. During the COVID period, there is one of the things we have to stop. Most of the healthcare professionals from BAME communities are foreign in the context that they were brought in from abroad, and they come here, they may be living here for many years. And during the COVID period, most of them could not communicate with their loved ones, and some of them have lost loved ones, and they couldn't attend funerals. Some of the people who came recently in the last 2 years were in nursing homes, and they've seen a lot of death and dying as well, people who haven't died yet. But the point is, there was no helpline for these people. There wasn't any, you would say, okay, contact your occupational health. There was no national helpline for them, which is something I was advocating for, a national helpline that they could actually ring and say, I am going through really difficulty right now. I don't think I can cope with a work environment. What happens next? What can I do? And there was nothing like that.
it was very much a blanket approach. So for me, the number one thing for me is the bullying, followed by the mental health and well-being of my colleagues.
Okay, I'm sure we could do another webinar very soon in the future about the whole mental health issue, because, we didn't get into that a great deal today, but it would be, great to do that. I mean, we're getting very close to the end now, so can I ask you the last question? I mean, if people wanted to be involved in what you're doing or find out more about what you're doing, where would they go?
Okay, so the first thing, BAME Health Collaborative is not racially grouped. So it's not only for the BAME community. We welcome everyone, because the whole mantra of this is that together we can. So we need everybody on board to help. So please don't think that, okay, I'm not a BAME and I can't be part of this group. No, we are on Facebook. It's called BAME Health Collaborative. And you're welcome to join us, because we want a fresh eye approach. We want your innovation. We want you to tell us where we're going wrong. We want to be transparent and open, and we're looking for new ideas. We're looking for that network. We're looking for you to guide us. This is new frontier for us. And so therefore, we're very open to that. And we also have a website, www.bamehealthcollaborative.org.uk. But the quickest way to find us, we are on Twitter, we're also on LinkedIn, we're also on Instagram, we're on social media. So it's very easy to find us. Just look up for BAME, B-A-M-E, Health Collaborative, and we welcome you on board.
Okay, well, that's really great. Thank you, for joining us, because I think you raised a lot of issues that people are aware of, but they haven't thought about. And also because of COVID-19, people are becoming more aware of the issues and more understanding of them. And so I'm sure what you've said today will help people understand even more. So, thank you for joining us.
Yeah, can I say something before I go? I think it's really important to say that we do have great champions in the NHS who are actually trying to make a change, but they can't do it alone. Some great CEOs, some great HR directors who are doing significant work behind the scenes and trying to make a change, but they can't do it alone. We all need to chip in together to make a change so that it's better for each other. And when you see any bullying and harassment, you need to say something about it.
Okay, well, I'm sure that people will, take account of what you said, and I hope, many people will get involved in what you're doing, because it seems that it's a really, really important thing at this stage that we're in society at the moment, when some of the disparities are becoming so clear in a way that some of us, I think, had shut our eyes to in the past, and many people had shut their eyes to. So, thank you very much for doing this.
Thank you. Thank you.
Well, I really appreciate it. So we'll end this interview now.
Thank you so much. Thank you, everyone, for watching.